All right, I'm going to talk about evidence from reversals to parachutes. All right, hopefully by the end of this, we'll all know what this title is about. Thank you all for attending so late on a Friday night. Thank you for being here. It's nice to meet you all. I think whenever I come and talk to people who've trained in a different system, I've trained in the US system, people always ask me my background. And I thought I'd just take 1 minute at the top to walk you through where I'm from and my background in the US to be a hemonc doctor. So I went to high school here, LaPorte, Indiana. It's just outside of Chicago. It's quite cold there. And the moment I finished, I said to myself, goodbye, LaPorte, Indiana. Goodbye. I'm not going to be back there. And I did my college at Michigan State University, which was nearby, a couple hours away. And I actually majored in philosophy. So we have to do 4 years of undergraduate in the US before we go to medical school. And then I went to University of Chicago, which is close to where I grew up. I did my medical school training there. And afterwards, I stayed on in the city, did residency at Northwestern University. And these are some happy pictures from those days, happy pictures from those happy training days. I see you have some trainees here, and they're probably having very happy days training here in Curacao, as I would too, if I were lucky to train here. I did my fellowship in hemonc at the National Institutes of Health between 2012 and 2015. And then I did a master's in public health at Johns Hopkins in that time as well. And I took my first faculty position in Oregon, and shown here is a picture of Mount Hood from Oregon. And this, oh, the slides got messed up a little bit. It's supposed to say, then I worked at OHSU for a few years, and then I worked at the University of California, San Francisco since 2020. And in my current job, I'm a hemonc doctor. So just like John, I take care of patients with everything from iron deficiency anemia, von Willebrand's disease, to rectal cancer, to colon cancer, lung cancer. I work in clinic in the hospital. And I'm a professor in the Department of Epidemiology, where I teach a few classes in the medical school and for the master's students. And I do research, and we run a laboratory. And anyone who listens to this who's really excited by that is welcome to join us. We have Zoom meetings, and we have a diverse workforce. We've got people joining us from Switzerland, from Portugal, from Spain, and we meet 3 times a week, and people can do research with us from anywhere, including Curacao. All right. This talk is about evidence and how to trust evidence and what kind of evidence you can rely on and what evidence is flimsy. And I think the talk before nicely set the stage. The Alzheimer's drug, is that the highest level of evidence out there? Is that really a game changer for people with Alzheimer's? Or would that money be better spent by hiring home health aides to the many people suffering from dementia? So this talk is about medical reversal. And I thought I'd define medical reversal right up front. I think for many people in healthcare and biomedicine, the way you think about medicine is shown in this picture. This is Henry Ford's Model T and Elon Musk's Tesla. Okay. I think when we think about automobiles, when you think about the phone in your pocket or the television on the wall, all we see is steady incremental progress. The phone you have today is more powerful than computers from when I was born, and that car on the right is better than the car on the left. We'll agree. We've made progress in technology and cell phones and imaging. And I think many of us think the same is true in biomedicine. Relentless, steady, incremental progress. And I want to say first off the bat that it is partly true. You know, there are examples in biomedicine where we had incremental progress and we've had wonder stories. Just think about the story of peptic ulcer disease. You know, it wasn't that long ago, 100 years ago, where the idea was it is a surgical disease. If there's no acid, there's no ulcer. And these surgeons pioneered things like Bill Roth 1, Bill Roth 2, these barbaric surgical procedures to cure you of peptic ulcers. Finally, we learned that the histamine antagonists and proton pump inhibitors actually could fight ulcers. And then Barry Marshall in his Nobel Prize-winning work learned about H. pylori. And now we treat with antibiotics and proton pump inhibitors, and with quadruple therapy, we have a really high cure rates of peptic ulcer. So we took it from a barbaric surgery to just a handful of medications taken for a few weeks, and you're rid of the disease. And that, to me, is the progress of the automobiles and the progress of the phones. Another example is Hodgkin's lymphoma. John takes care of patients with Hodgkin's. If you would read the history books around World War II, if a soldier was diagnosed with Hodgkin's, they would die before the war was over. There was no treatment for Hodgkin's. In the 1950s at Stanford, they started to give radiotherapy to people with Hodgkin's, and they could cure a few patients, albeit with great toxicity. And then we moved to combination chemotherapy like MOMP and MOP, and finally ABVD, which was pioneered in the late 60s and 70s, which remains to date, I think, the standard of care and has cure rates in the 90 percentage points for people with Hodgkin's. So again, slow, steady, relentless progress. I'll skip the last one. But at many other times, I think the narrative in medicine that's different than technology is that something we have been doing for many years, that we have been training our students to practice, that we have been pushing by professional societies, was found to be no better or worse than a prior or lesser standard of care, including doing nothing. We made a leap. We took a leap. We invested in some new technology, and it turned out it was actually no better than if we hadn't done it at all. And that's what we call medical reversal. Some medical practice we adopted that entirely flipped on its head. One example is the routine use of the Swan-Ganz catheter. I think if you trained in the United States in the 1970s and 80s, any patient who came in with shock, low blood pressure, you'd place a Swan-Ganz catheter into their, ultimately you wedge it in the pulmonary artery, but get the pulmonary artery pressure, but you insert it into the IJ. And you'd monitor the pressures in their heart, the cardiac output, and you would take that information and you would use that to change the amount of pressors you're giving somebody, the inotropes. You'd use that information. And then in multiple randomized controlled trials, the routine use of Swan-Ganz catheter was shown not to improve outcomes in shock. And so we don't do it. And in fact, you can have complications. You can actually wedge it out so far, you have some ischemia, necrosis piece of the lung. Stenting for stable angina. I think in the 2000s, stents were predominantly placed for chronic stable angina in the United States. And in a number of papers in the BMJ, they asked patients who are undergoing stenting, why are they stenting you for stable angina? And the patients were saying it would extend my survival and reduce my risk of heart attack. But of course, the randomized trial Courage has shown that it doesn't decrease heart attacks and it doesn't improve survival. And then in an elegant paper by Daryl Francis and colleagues called Orbita, they show that stenting does not even improve the symptoms of stable angina when you have a placebo control, the sham procedure. So to me, medical reversal is much more like this. I don't know if you remember this. This is a Volkswagen Beetle. People bought this diesel automobile because they cared about climate change. This was supposed to be clean diesel, put out less pollution. But actually, Volkswagen had a little glitch in the chip, and it put out 30 times as much atmosphere trapping gases. You know, it actually was much worse for the atmosphere. Okay, so medical reversal to me happens when a large, well-done study, typically a randomized control trial, some study that has better blinding, better control, better power, and better endpoints, in other words, less bias, contradicts current clinical practice. And it's ubiquitous in biomedicine. We're going to talk about that. And we can talk about what are the things we're doing today that might someday be reversals. All right, so let me get into some examples of it. When I was in training in 2014, there was an outbreak of fungal meningitis in the Northeast of the United States. And this was when methylprednisolone injections were contaminated with aspergillus in a compounding pharmacy. And when doctors injected the methylprednisolone in the backs of patients, some of them developed fungal meningitis and a few people died. And many people were outraged that this compounding pharmacy was engaged in filthy practices and contaminated all these steroid injections. And don't get me wrong, that bothers me too. But the other question I had was, why are we injecting so many people in the back with steroids? And the answer is, this is one indication, spinal stenosis. If you deliver a steroid injection to people with spinal stenosis, you might make them feel better. After all, the stenotic spine is inflamed right at that level, and the injection of the steroid is a long-acting anti-inflammatory. And indeed, if you take somebody suffering from this and you just do the procedure, a lot of people say, I feel better. What more do you want? Well, they did a randomized controlled trial with a sham control. This is from the New England Journal of Medicine. In one arm, they performed the injection and it's lidocaine and salt water. In the other arm, it's lidocaine and the glucocorticoid, the steroid. Now, lidocaine is a short-acting anesthetic. So lidocaine will make you feel better for a few hours, maybe a day, but lidocaine's not going to make you feel better 5 days later or a week later or 3 weeks later. The only thing that can make you feel better 3 weeks or 6 weeks later is a long-acting medication like a steroid. Okay, so only one of these two groups gets a steroid. And these are 7 different dimensions of pain and physical function shown here. One group just gets salt water. One group is getting the steroid. What you see is both groups get better, and there's no difference between the two groups. That the steroid injection, although it's invasive and expensive, has a placebo effect. It's only working as good as a placebo, salt water. And so my problem with this procedure is in part, why is the compounding pharmacy dirty? But also in medicine, every time you do something to somebody, you take risk. And it is inevitable that some of these will be contaminated. It's inevitable some people will bleed. And the real question is, why are we doing it? And the answer is, it appears to be rather poorly supported. You would get the same benefit from salt water. Okay, I picked another fun example. When I was a trainee, I would go to allergy immunology clinic. And we had a lot of patients who would wake up with allergic rhinitis or asthma symptoms, and we would screen them for allergies to the common dust mite. And the idea was that if you have dust mite allergies, then maybe if we wash your bed sheets, if we put some covers on your bed sheets, we can prevent those dust mites from kicking the dust up when you're sleeping. And when you wake up, you have less asthma and less runny nose. And in fact, you could buy these kinds of things. These are allergy-proof bed sets. And this is an electron micrograph. On the bottom is your traditional sheets. Look at all those holes for dust mites to go in and out of. And on the top is the impermeable bed cover. And anyone who's ever slept on these knows it's like sleeping on rubber sheets or something like that. And this was a lucrative industry. It was a tens of millions of dollar industry. And then they did a couple of randomized controlled trials. One group got the impermeable bed covers, and the other got sham impermeable bed covers that had holes poked in them, but still felt as uncomfortable. And they measured peak expiratory flow rates. They measured whether or not it was in everybody or in mite-sensitive patients. And what they found was no statistical difference in symptoms of asthma or allergic rhinitis in these two studies in the New England Journal of Medicine. So again, it's extremely plausible that blocking the dust mites would help. The reality is, when you randomize people to that, it doesn't. I'll skip that for time. So how often does this happen? You know, I think we can think of many other examples. We can think of the example of hormone replacement therapy. We talked a little bit about stenting. We can talk about, you know, some of the drugs we use for blood pressure, like atenolol, that look like they don't work nearly as well as other drugs.
You have to have a screening test that finds more cancer if you didn't do the screening test. And actually, not everything that people endorse even does that. For instance, the self-breast exam. In the study out of Shanghai, the self-breast exam did not actually find more cases of invasive or in situ breast cancer than not doing the self-breast exam. And shown here is deaths per 100,000 years after randomization, the self-breast exam or no self-breast exam. You do have more biopsies, you find a lot more lumps, but you almost exclusively find benign breast lumps and not cancerous breast lumps. So self-breast exam, I think, has no value. It doesn't improve survival, as shown here and confirmed in a study from Russia. Most things we I do offer, do find more cancer. Mammography finds more cancer, PSA screening finds more cancer, lung CT screening finds more cancer. But the next question is, does it reduce disease-specific mortality? By doing mammograms, do you actually reduce the risk of a woman dying from breast cancer? And that question is actually complicated because you may find cancer, but not all cancer is equal. If you find cancers that grow very, very quickly, those cancers may have already spread when you find it on the mammogram, already metastasized. And finding that cancer and cutting it out of the breast doesn't improve survival because it's already spread and it's already going to cause some problems. The fact shown here. If you find a cancer that's really, really slow growing, it's never going to cause harm in a woman's lifetime, that's shown the non-progress, the snail at the bottom. And that cancer, if you didn't find it, was never going to cause harm in a woman's lifetime. The cancer you want to find are like shown here, depicted as a bear, we often call it a rabbit analogy, a cancer that was going to cause harm in your natural life, but because you caught it and cut it out, it's not going to cause harm. And the problem is, there is nothing on the pathology, there's nothing about the appearance of the tumor that actually tells you which of these you're finding. It doesn't look different on the slide. And when you do cancer screening, you find a lot more, all three of them. You don't know the ratio of what you're finding. So this is an example of the CA-125 and transactional ultrasound for ovarian cancer screening. What you see here is an increase in cases over time on the left, but no reduction in ovarian cancer death on the right. You find more cancer, but you don't lower mortality from ovarian cancer. And so actually it's not about the United States. Well, the third thing is by finding more breast cancer, removing it and less breast cancer death, people actually live longer for any reason. So let's consider this problem. First thing here, I'm going to show you is a paper by Russell Harris. And what it looks at is women in different age groups and the risk of death from breast cancer. And what it shows you is as time has gone on, becoming more modern studies, the risk of breast cancer mortality is smaller and smaller benefits. The biggest benefits were seen in the earliest, this laser's not so great on this. The risk of the benefit was seen in the earliest studies, and that gets smaller and smaller in future studies. Okay. Another way to look at this is non-breast cancer death. Okay, so if you take all the randomized trials of breast cancer and you look at the difference between the two arms of dying of something other than breast cancer, that's shown in this big disease score for that. Now, if you do mammograms on women with breast cancer, you're supposed to find breast cancer, move the breast cancer, less death from breast cancer. But you're not going to find Hodgkin's lymphoma. You're not going to find colon cancer. You're not going to find other causes of death. You're not going to lower other causes of death, and also the radiation dose is small. You're not going to increase other causes of death either. And what Peter Juni is showing you here is the difference in non-breast cancer death in these studies. And as you know, several of them have big differences in non-breast cancer death. They're above that line and they're below that line. Those are statistically significant differences in non-breast cancer death. Peter Juni doesn't think that's plausible. That's not consistent with an effect of mammographic screening. It's much more likely due to an error in randomization or an imbalance in randomization, which was quite likely back in the 70s when randomization was not a perfect science. And he said, let's take the studies in the middle where there looks like there's no, inconsistent effects and compare them to studies on the outside. He does that here. On the top, we look at the studies where the non-breast cancer death is the same as we expect it to be, and it has a small reduction in death from breast cancer. On the inconsistent studies, they had a much larger effect on death from breast cancer. So we think mammograms work so well, in part because we hang our hat on studies that are really problematic, that have errors in randomization. And if you look at all-cause mortality, the story is very clear. If you look at the consistent randomized studies, there's just no impact of mammographic screening at any age on living longer. You don't live even a day longer. I think this is also shown recently in the NICE paper in JAMA Journal of Medicine. In the inconsistent studies, they look like there's a small benefit, but again, those studies have some key issues with that. This has also been shown by Peter Gocha and Karsten Jorgensen in the Cochrane review that shows there's just no impact on mammographic screening in the adequate randomized controlled trials. There is some impact in the non-adequate randomized controlled trials. If you look at all-cause mortality, it's just a wash. Pause here, and I'm just going to say my conclusion here is basically when you have a fixed budget for a healthcare system, and there are things we can be spending that on, like better outreach, better blood pressure control, better treatment for lymphomas that are curative. To me, cancer screening is the worst thing to go after. It sounds good, it feels good, it turns a lot of healthy people into patients, and we have very little idea if they are less likely to die of a target cancer, and even less idea if they're actually live longer as a result. And it's very likely that they don't. And so we have medicalized a huge swath of society, and I'm not sure we're getting a commensurate benefit. Okay, I'm going to take some questions. If people are interested in this talk, I would say check out my paper. Check out my YouTube channel. There's a Substack I write called Sensitive Medicine. Podcast is filmed there. Currently that good, and a book. Thank you for your time.
Questions? Yes. Yes. So if I understood your presentation well, by the way, should we start doing randomized controlled trials and looking at things like quality of life, happiness of people instead of mortality and other endpoints?
That's a great question. Yes, the question is, should we do randomized controlled trials for happiness, quality of life? Absolutely. So I think that in many surveys of people, particularly as they get older, you ask people which they value more, living longer or living better. People say living better. Some people say they value living better even at the price of losing a few years of life. So that's what people want. We have done a terrible job of capturing quality of life in randomized studies. We survey it poorly. We don't survey everybody. People who are sick and have side effects don't get the surveys. So we should do a good job of making sure that the drugs that we think make you live longer, who don't reduce your quality of life. And then the next point is, should we have more interventions that are done to just improve your quality of life without extending survival? Yes, that should be the focus of medicine. The quality of life matters much more than longevity for most people. Ideally, you do both, ideally. But if you can't do both, we should see what people want. I think more people would rather live well than live longer.
Other question? Yes.
Prasad, I really think that you are not making editors of the big journals happy, and also not the FDA, probably also not the EMA, the European. So you are what we call in Dutch with a proverb, which you are called from a desert. We don't hear you because we don't visit the desert. But how are you going to change this? And you presented quite a few very good examples, but why are you right and not the editors of the New England or the FDA?
Okay, so let's do the second one first. I think that the best case for, at the end of the day, how do you know anyone's right? Everyone in the audience has to use their own mind. So my goal is just merely to offer you my perspective, and I hope I persuade perhaps 5% of you. If I persuade 5%, I win. I would point out to the structural differences, because the journal editors and the professional societies and the companies are all presiding over a system where tremendous revenue is created from the generation of these products. The amount of capital that moves through global markets in the sake of health is tremendous. And no other time in human history has so much human capital been amassed and put in
Pursuit of living longer, in pursuit of health. The irony to me is that it is extremely misspent. If you took the same GDP and you actually sat down and said, how can I maximize the longevity and life expectancy of this population, you would spend in almost nothing that we're spending it in. Everything we're doing is almost backwards. Now, and why do we do that? My perverse answer is that that's what makes people rich. Because if you spend on all the things that actually makes people healthy, better schools and better nutrition and better childcare, better primary care doctors and more compassionate care, somebody to come to your house and do your laundry when you have Alzheimer's rather than medicine, you make a lot of people have jobs, but you don't make a few people rich. And so our system, I think, is predicated on making people rich. And a system that makes some people rich, that consolidates power, will always be promoted by the people in power, the journals and the editors and then the professional societies. And so I think my best case for why I'm probably right and they're probably wrong is that the structure favors them and not me. Okay, then the next part of your question. Okay, I'll let you come to. You want to say something about that?
You still remember the question of one of the residents last Thursday that she got depressed.
Yeah.
Because we, probably the educators, are basing their teaching upon the results of studies that you just, crashed. What is it? Demolished. So how are we going to change that? What is your advice?
Yeah, my advice is, So I think we've been talking about this. It's a great question. How are we going to change this? And I give the same kind of answer I gave on Wednesday, which is that people like Ashley and John and yourself, I think level one, if we can train the next generation to see things a little clearer, I think that's going to help. I don't think you're going to succeed with every single person in training, but if you succeed with 5 or 10% of students, every year I have a few students that I think really get it, and they go on to do great things. And the multiplier force of a few well-trained students, I think, is tremendous. That's one thing. The second thing is I think we do have to have more of a say at EMA. I mean, the Netherlands has struggled with dealing with EMA decisions. EMA is approving everything. They're approving everything, and the Netherlands has to say no. And why they say no. Other European countries like Germany might say yes. They have more money, perhaps sometimes. Switzerland might say yes. They spend more money. And then Netherlands is in a tough place. To the public, it may look like you're saying no because you're not willing to spend the money. But they may be saying yes because they're foolish. How do you convince the public that this is something that we're doing that's in the best interest of everybody? In the United States this week, I mentioned this on Wednesday, there is a debate, and I was looking into this more, it caught my interest. There is a woman with metastatic lung cancer, non-small cell. She has multifocal non-small cell lung cancer in both lobes of the lung. This is considered incurable lung cancer. 100% of these people have microscopic disease outside of the lung. And some doctors in one hospital, Vanderbilt, have offered her a double lung transplant for metastatic lung cancer. Okay. The insurance company said yes. Then at the last minute, they say no. It's millions of dollars to be spent. And then there's an outrage on Twitter. And now the insurance company says, yes, we'll do it. And what I say, American medicine, we're talking about lung transplant for somebody with metastatic lung cancer, millions of dollars. If you have emphysema, even lung transplant, I'm not sure you're better off because death from lung transplant is terrible. It's one of the worst organs to get transplanted. But certainly from lung cancer, it makes no sense to me. So American medicine is so far off the deep end that I think it is a challenge for everybody. But how do you tell the public? I look through the comments. There are doctors who say, it's outrageous, we don't pay for this. It's horrible, we don't pay for this. The doctors are saying, how do you deal with a system where the doctors think this is worth our pursuit of money? I think it's a great challenge. All I can say is discussions like this and this conference are the best answer. And hopefully we can make some changes over time. But I think it's the toughest question of our day. Thank you for that.
Okay, final question, Dr. Gerstenbloed.
Thanks very, very much for this. And I don't want you to get me wrong either, but there's a lurking problem. What you say is I fully agree. But as you know, like in COVID, we've been exposed to conspiracy theorists, Facebook, social media, activists, etc., without them having any basis on good research as well, but shamming whatever it is that we were saying. Now, this complicates matters. If we ourselves start pointing out the flaws in our own research, we're prone to fuel other issues as well. You understand what I'm saying?
Yeah.
So how do we deal with that?
This is great. This is the greatest question. You know, this is the greatest. I think about this so much, and I'll rephrase the gentleman's question. The gentleman's question is basically, as I understand,
not a gentleman, far from it. But anyway, that's besides the point.
I'll try to summarize it, which is that you know, the talk I gave you was very critical of the establishment view. The establishment view on a number of medical products is not what I think it is. And tomorrow I'll talk about more. I talked about on Wednesday with Entresto. There are many things that are being sold to us. Establishment view, maybe it's not as rosy as presented. Now, this person's making the point that if you keep criticizing the establishment view, there's an alternative view, which is what I call the crazy view. People who think that the Wi-Fi caused COVID, or COVID doesn't exist, or, you know, that, you know, all sorts of things people believe, like completely ridiculous beliefs that are not based in science. And this group of people is getting stronger. And I agree with you. I think they're getting very strong. I think they're the strongest they've ever been. And the next 10 years, they're going to be stronger and stronger. And what I see as the failure is that those of us who believe in science and believe that medicine and universities can be the great force of good, we have to be nearly perfect to not give them an inch. If you're not perfect, then they're going to gain ground. And I do think in the pandemic, which I'll talk about tomorrow, we have so many missed opportunities where we didn't generate evidence. We recommended things and we forced them on people with poor evidence. In the US, we pushed things on very young populations, children. We deprived them of school for years. We did lots of things that were great errors. And the group of people who don't believe in science have gotten a lot stronger as a result. And I agree with you that that is a huge threat. If you don't believe in science, then you don't believe in reason, in my view. Meanwhile, those of us who believe in science, we cannot let it be captured by corporate interests. And so we have to find the balance. And this is, you know, like Odysseus taking the ship through the two. Yeah. Thank you.
Thank you very much. We have to address